Okay, we're going to go ahead and get started and welcome everybody to Talking Public Health. Today we have Maura Kepper, who's an assistant professor of public health. She warned me that her bio is very boring, and several of us offered to jazz it up, several people in this room, and then we decided she probably wouldn't like that. So she also told me to keep it short, but I'm going to pretty much read it close as is. I'll shorten it a little bit. Are you embarrassed? So Moore's research seeks to improve care for people with chronic conditions. It's driven by collaborative design methods. She engages key partners in the role of complex systems in health and healthcare. Her research integrates behavioral health, informatics, and D&I science for impactful interventions. She also employs epidemiologic methods, evaluates effects of environments on health, and works to create, implement, and sustain interventions that are targeting chronic disease. A significant area of her work is technology and big data to promote healthy behaviors around physical activity and diet and to address social needs and quality of care. She's published extensively in these areas. She co-directs the Health Design Impact Lab. She works with School of Public Health Prevention Research Center and WashU Medicine's Institute for Informatics, Data Science, and Biostatistics. She must be a very boring person because everybody wants to work with her. Kepper, sorry. Moore is an active member in American Heart Association's Social Determinants of Health Committee. She co-chairs Society of Behavioral Medicine Digital Health Special Interest Group as well. And she, as her training, she's not UNC, so I can't take a dig at that. She completed her postdoc training at Pennington Biomedical Research Center and got her doctorate in public health from Louisiana State University Health Sciences Center and is a Delta Omega Honorary Society and Public Health member. She's been supported in her research by National Institutes of Health, American Heart Association, Blue Cross Blue Shield, yada, yada, yada. So with that boring intro, I'm going to turn this over to Maura.
Okay. Thanks so much, Deborah. I hope my talk is not as boring as the intro. We'll see. Jokes aside, really excited today to present to you I titled this From Insight to Impact, which is designing sustainable and context-aware and personalized care for chronic conditions. And I want to caveat, I'm doing quite a bit of talking today about works in progress because I think since joining the School of Public Health, Sarah and I co-launched this lab, the Health Design and Impact Lab. So I'm really hoping today gives you a flavor of what our lab is about and what we do. Personally, my work seeks to improve care for individuals with multiple chronic conditions in kind of three key ways, and I'm going to talk you through those ways with some examples today. So the first is I seek to promote healthy behaviors and really mitigate the impact of adverse social determinants of health on patients, really across the life course. So I do some work in children, but also in adults, so you'll see that today. I develop and implement digital tools that focus on improving personalized care and context-appropriate care, so fitting into the system in which it's delivered. And then to do this, I use methods like implementation science. I'm starting to learn a lot about system science, but really that's Sarah. And I do a lot of human-centered design, really engaging the community deeply in developing these solutions so that we can reach more people and sustain impactful interventions over time. So I'm going to talk about three. I actually snuck in a fourth thing I'm going to talk about today in these three areas. I wanted to start to talk to you a little, just like 1 minute, about my postdoc work and my early work, which was much more epidemiologic or etiologic basis, and it really provides kind of what I focus on today, although I've moved a little bit away from this. So all of my work uses the social ecological perspective, and I really focused my early work in three levels: the individual, the interpersonal, and the environmental level. In my postdoc work, I used a lot of mixed methods to examine how social and physical environments impacted parenting behaviors and how that translated to kids' outdoor play and then their obesity and cardiometabolic risk. So we found that parents who live in neighborhoods with high incivilities, so these are things like dilapidated homes or graffiti or vacant lots, they have lower levels of perceived social capital, and they were more likely to impose restrictions on their kids' outdoor play. And this translated to kids having less overall physical activity. I'm not going to go too much into this, but I really just wanted to present this to show that my early work focuses on these multiple levels. And now I've really, since coming to WashU, included informatics and dissemination implementation science to this previous training in behavioral science and EPI to take that evidence to intervene and translate this science into impact. So first, I'm going to talk to you today about the PREVENT trial or study, which really addresses the need for improving physical activity and dietary counseling or health behavior counseling for patients who are at risk for poor cardiovascular health. Physical inactivity and poor diet are part of the Life's Essential 8 that the American Heart Association put out as key risk factors for poor cardiovascular health. And there is some evidence that health behavior counseling provided by a clinical team can improve those behaviors. But clinicians really don't know how to do this in a way that's personalized to the patient and in a way that fits within their routine care, which often has a lot of competing demands. So we developed a tool called the PREVENT tool. It's really designed to be used by the healthcare team in a clinical encounter with a patient to talk to them about their cardiovascular health, but also provide evidence-based recommendations for physical activity and food intake that are personalized to that patient, using a shared decision-making or motivational interviewing approach. So we used human-centered design to develop this tool. We really engaged the clinicians, but also patients in the development through this iterative process, which you're going to see I use quite a bit. I'm going to present the very first step of a human-centered design process because I think people always gloss over this, but I think it's probably the most important, which is really let's engage end users to understand the problem. We as researchers often think we know what that problem is, and we do have a pretty good idea, but really thinking about how do they think of the problem, what are the pain points for those end users, what are they trying to achieve, allows you to build a tool that has value for them. And that is most critical for buy-in and long-term use. So what we saw when we talked to clinicians about what they needed to improve care for obese patients in their clinic visits, they had a number of pain points, as one would imagine. There's limited time in that clinic visit. They have a difficulty assessing the behavior, so they don't even know where the patient is starting in terms of physical activity and food intake. They struggle to motivate patients. They don't know about resources to provide to these patients. And these patients are often challenged by a number of things outside that clinic, those social determinants of health, that provider doesn't really know how to address. What were they trying to achieve? It's simple in many ways, and it's what you would expect, but really they wanted to deliver goals. They wanted to deliver goals in counseling that were useful for that patient. They wanted to change their patient's behavior and increase their knowledge and help them improve their health. So to address those pain points and help these clinicians, we developed this tool. The first step of the tool is a patient profile that displays the American Heart Association's Life's Essential 8. It used to be the Life Simple 7, but we've transitioned to the 8 now, which includes sleep. And basically the tool has the 8 risk factors pulled in from the electronic health record or survey data from a patient. It displays them using this color coding to say poor is red, intermediate yellow, green ideal health. And it uses the American Heart Association algorithm, not one I developed, to create that overall cardiovascular health score at the top and display that so that clinicians can use these interactive slider bars to demonstrate, for example, that if you improve your physical activity, your overall cardiovascular health will improve. To me, this is a nice way to set up then the goal setting where we can actually encourage and motivate patients to work on their physical activity and food intake behaviors. Okay, the next step, let's see if this works. Yeah, Okay, here we go. So the next step of the tool is facilitating a shared decision-making conversation to set goals with the patient. The tool recommends goals that are personalized to the patient based on their current level of behavior, but also their obesity status. And then the provider works to operationalize how they're going to achieve those goals. What you're seeing now is the resource map. So this resource map includes all types of resources. It functions very similarly to any map you use on Google, but it pulls in resources from Google Yelp, but also has a crowdsourcing component, which I'll talk about in just a bit. And this is a way that the clinicians can provide resources to the patient for physical activity and food intake, but also all types of social needs. And we also have in the tool a digital resource library. So this is if the resource has a physical address, but we also have all types of digital resources, a lot of them developed by the American Heart Association, but other things as well that you're seeing here. After the patient has that goal-setting conversation, they receive a summary or care plan that's electronically delivered to them by text, email. They can print it. And then the tool automates monthly follow-up with the patient, asking them how they're doing on their goals. If they're achieving it, it doses them higher, or it maintains that goal and encourages them to keep working on it. All of that feedback is fed back into the tool so the care team can monitor progress over time on how a patient is doing on their goals and see what barriers they're facing so they can reach out to that patient to further support them. So we have tested this tool across 2 studies. We conducted pilot testing of this tool in 4 clinics and 96 patients with obesity. We demonstrated the ability to recruit these patients and randomize them into an intervention or a waitlist control group. We then looked at whether the use of the tool translated to changes in knowledge, motivation, and behaviors and their overall cardiovascular health. But of course, these are pilot studies. So our main focus was the feasibility and the implementation of this tool. One of the trials was among adolescent and young adult cancer survivors, because we know that those individuals who go through treatment have a higher likelihood of developing cardiovascular disease. And so this was 50 patients. They were between the ages of 15 and 39. And 20% of the samples below the federal poverty line, 16% were food insecure. And so what we saw is that individuals in the intervention group did have improvements in their self-efficacy for physical activity and food intake, which is a known precursor to subsequent behavior change. And truthfully, this is a 3-month follow-up. So we didn't really expect to see changes in behaviors or cardiovascular health. We weren't powered to do so, but things trended in the right direction. So that was really positive for us. The other sample was from the Healthy Start Clinic at BJC, which is an obesity-focused clinic. It is a highly African-American, low-income population. So you're seeing 23% were unstable household income and 40% were food insecure. We did not see as many changes in behaviors or self-efficacy in this study, but we did have in our intervention group, we saw improvements in their overall cardiovascular health. So like I said, these were pilot trials. The main focus is feasibility and implementation. So we used a lot of mixed methods to look at these outcomes of feasibility. What were the barriers and facilitators to implementing the tool? How did people perceive the tool, both the patients and the clinicians? Did they like it? How did it fit in workflow? What did we have to adapt through these trials? And what's the perceived sustainability? Would people want to keep using it? So those are some of the metrics we looked at. I'm not going to present all these today, but I'm going to talk about a few. So on average, providers spent 7 minutes using the tool. And this is quite a bit of time added to a visit, but you can see in one of the quotes that they actually felt in a lot of ways it improved the quality of care and in some ways sped up the delivery of health behavior counseling because they had all the data right there in front of them and they were able to have a very actionable conversation with the patient somewhat quickly. We did notice that patients, they overall were receiving quite a few resources, so that went well, but rural patients received fewer resources, and that was problematic because we realized our map was not necessarily working well in rural communities, and so I'll talk about the changes we made based on that. We heard that this tool was user-friendly. They felt it was easy to use. It was of critical importance in a clinic setting where time was limited. I mentioned they felt it was quick to use. The key barriers at this time, the tool was not integrated into the electronic health record, which Mary kind of teed me up for this last week. Everyone wants everything to be in the electronic health record. There are positives and negatives to that, which I'd love to chat about another time. And while this tool was relatively short, it was a few minutes they had to use it, there are a lot of competing demands. And so adding this other step to their clinic visit was a challenge for some providers. We also learned that maybe our training was not quite enough, right? Some of them felt like they needed more practice. They felt a little fumbly when using it. So we've made a lot of updates to the tool and both our implementation strategies based on these learnings. So I used findings from this trial, and I'm actually combining those with other trials that I either lead or serve as a co-investigator on as an implementation scientist to really think about what are the common barriers and facilitators across studies that are implementing digital health tools in clinical care that we need to be addressing. We're conducting a systematic review, and Amanda Gilbert, who's here, is leading that. It's actually an umbrella review of reviews to look at this topic of what are the key challenges and facilitators across a number of studies. There were so many reviews that we have now broken it apart, and we're actually working on 3 papers, one on AI, one on mHealth, and one on digital health tools focused on chronic disease prevention. And the goal really of all of this work is to think about what kind of implementation strategies do we need specific for digital health? I think the traditional ERIC implementation strategies in our field don't quite fit a lot of the needs of a digital tool. And so we're thinking about what do we need to put out there for common strategies in this space. I mentioned we saw that our tool wasn't working as well in rural patients. And we had the opportunity to partner with Missouri Highlands Healthcare to actually adapt our tool and start implementing it in their clinics and testing it. So through that adaptation process, we worked with a number of community partners. Probably most importantly here was that Butler County Community Resource Council, which was already a hub for resources in Southeast Missouri. And we tried to update our map and think about solutions to how to make a resource map like that work in these communities. And what we landed on is resources, as many people I know, Matt's over here nodding, know in this room, is they turn over, they change a lot, particularly in rural settings. They're in a church for 1 week, then they move to another location. And so we really needed to leverage local knowledge to make this resource map work for this community. And so we amended the tool so that community health workers, because they had community health workers embedded in their 10 clinics, could add resources to the community resource map and actually click them as, quote, locally verified and communicate about resources across the 10 clinics in their system. We are currently funded by American Heart Association and HLBI to test this tool in their clinics. So they have 10 clinics. We're currently testing it in 4, but I just had a meeting earlier this morning. We're going to expand to more of their clinics to try to get more patients. We're having a bit of trouble enrolling these patients, but our goal is to enroll 140 patients who are overweight or obese, 18 to 64, and look at whether using this tool in the clinical care visit with a clinician and a community health worker translates to behavior change in cardiovascular health. So I mentioned briefly that this tool has all types of resources. It in fact actually started with just physical activity and food intake resources, But we quickly learned everyone wants more. They want all types of resources to address social needs. So we expanded our resource offering. So you can see there's all types of things for education, employment, housing and utilities, income support. And this is kind of another passion area of mine, is how do we actually screen for and address unmet social needs in clinical care settings? And that could be by providing resources like this, but there's also ways of adjusting care for types of social needs. And so I've done a number of studies in this space. I'm not going to go into that too much today, but this is an area of research I want to keep building on. And the latest thing we did is through the ISC3, we actually collaborated with a number of universities in that network to develop this pragmatic guide to help clinics implement social risk assessments. And through that, we worked with a number of clinics across the US to test the guide. And that was a really, really wonderful learning experience in this space. So I really put this up to say, if anyone wants to collaborate in this area of research, I would like to. Okay, so now I'm going to talk to you about two other projects I work on with St. Jude, and really highlight how my expertise in design and implementation can really enhance personalized, context-appropriate care. I really am interested in how do we design digital tools. So I lead a working group within the Society of Behavioral Medicine that is a collaboration of academics, but also industry partners in the digital health space. And through that, I've got to publish a number of papers on actual design methodology, which has been really fun. Okay, so the other part of my research is really thinking about how do we go beyond just designing that tool, so the UX UI component of a tool or the product itself, and consider how that tool fits in context and how it will be used, disseminated, and scaled to generate lasting impact. So within implementation science, we have to have the jargon, and so this is called Designing for Dissemination and Sustainability, or D4DS. And what you're seeing here on this screen is the fit to context framework for D4DS. And that really aims to support that research product adoption, implementation, and sustained impact on health and health equity. So really the idea of D4DS is quite simple. It's let's begin with the end in mind. So the idea that we should consider from the start in that really conceptualization phase of how our products of research, whether that's an intervention, a digital health tool, maybe it's a methodology or a policy, how is that thing going to fit in the context in which it's going to be used? And how's it going to be scaled to other contexts and sustained within those settings to generate the intended impact over time? So I'm going to talk to you a little bit about how I have applied this thinking in my own work, and then I'll end with another D4DS component. Okay, so this first project is called the ARIA Guide. This is very much a works in progress project. This is a digital health tool being developed by St. Jude Global and the International Society of Pediatric Oncology, or SIOP. This is a massive effort. You can go to ariaguide.com right now. You can see this tool. It is a tool that's seeking to adapt care guidelines across diseases, supportive care, palliative care, and survivorship care, really to increase the implementation of guidelines in low and middle income countries across the world. Our team is focused on the survivorship component of this platform. And so we've been partnering, Sarah and I have been partnering with a number of people at St. Jude who are experts in survivorship care and global survivorship care, and focusing on how do we design this survivorship component of the tool to increase the use of evidence-based survivorship care guidelines for survivors of pediatric cancer. There's kind of a number of components of this. So first is the content generation. We're taking guidelines and adapting them for these contexts so that they can feasibly deliver evidence-based care. So imagine, you go into a low and middle income country, and we've developed a guideline here in the US that requires they have a certain I don't know, X-ray machine or whatever, and they don't have that, what is the next best thing they can do? That's what this tool is seeking to provide. My role is, as you might imagine, thinking about the design interactivity. How are clinicians going to access this and engage with this content? So you can see there is nothing there. This is all grayed out because that's what we're designing right now. So I'm going to talk to you a little bit about how we're doing that. We are using a user-centered design approach. We're engaging clinicians in this iterative process that builds over time. I'm sure a number of you are familiar with this, but really seeking to identify user needs through a number of methods. Think about what they need and design it with them. Developing wireframes or really drawing and mocking up what it's going to look like with these clinicians all over the world. And then we'll test the usability of that and integrate user feedback. This was a large charge from St. Jude because they're trying to design something that works for everyone in low and middle income countries everywhere. So when I think about how do I run a user-centered design process designing for clinicians in all countries, it was quite a challenge. So we are engaging a lot of oncologists, about 90, not oncologists, but also specialists and primary care physicians, because those are often the types of clinicians who are delivering care in low and middle income countries to survivors. And we're engaging them in 9 design sessions. But we wanted to make sure they were diverse in terms of their specialty, but also in a number of other ways. So the way we did that is creating these personas. And this is our way of being sure that we have people who are located all over the world in different income levels, but also diverse in terms of their experience in delivering survivorship care, their motivation to practice evidence-based survivorship care, and their digital literacy or comfort using a digital tool within their care delivery. And so our approach was we sent out this very broad survey through St. Jude and through their organization partners. And we have 200 responses of people all over the world who are providing survivorship care, and we are now recruiting them to engage in our user-centered design process. We also submitted an R01 because the ARIA guide has not only the content component, but also a place for interactive care tools. So these are things that would support clinicians in delivering care. So think about like a therapeutic dosing calculator or a staging tool. And so this grant is actually to think about how do we help them generate personalized survivorship care plans using those context adapted guidelines. The grant would design it and then pilot test it in 4 low and middle income countries. So this is in review with NCI. Okay. The other piece of this is how is this tool, I mentioned survivorship care is quite messy. So even here in the US, there's no clear model of survivorship care. Sometimes they stay with an oncologist for up to 5 years after the time they've, quote, been cured, or sometimes they transfer quite quickly to a primary care physician. And then you take that outside the US and it gets even more complicated. So these systems of survivorship care and how this tool fits in a survivorship care pathway is very important to us so that we can understand who's going to be the user of the tool, but also what kind of implementation supports do we need to provide to support the use of the tool. So this is admittedly not a perfect model. This is a mock-up, but I wanted to demonstrate how we use both design of a product, but also system science or other types of thinking to really think about how this tool is going to fit and be used over time. So I think Sarah will talk to you more about this in her talk in a few months, but I wanted to set you up there. Okay, the other thing we're doing in relation to this tool is working with some implementation scientists at St. Jude who am really thinking about how do we generate those implementation supports and dissemination strategies for this tool. I mentioned they want everyone all over the world to use this tool, so we've got to think pretty creatively about how we're going to support that. So we're doing a pre-implementation assessment where we're really identifying barriers and facilitators to uptake, which we will then use to inform implementation strategies. And we're in the process of working with them to really develop a multi-level implementation strategy where we're providing supports for an individual user of a tool, but also thinking about how do we leverage St. Jude connections, because it is truly an amazing place in terms of that, with agencies, societies, and governments to support the use of this. And St. Jude has a really robust regional network. They have regional hubs all over the world. And so we're thinking about how do we leverage those hubs to support the use of this tool over time. So this is I keep saying this is a massive effort because it really is. And there's a lot of different contexts of use. And so we're trying to think, how do we apply an iterative implementation science model that's going to be a continuous way to learn and improve our implementation of this tool, but also of the digital platform over time in a way that's pragmatic. And so we're developing out a pretty robust digital metric system so that we can look at these re-aim outcomes of how many people are we reaching, what's the representativeness of our users, how many clinics are adopting the tool, and where are they? And then what does the actual use of specific features in the tool look like? So we're using click data to look at, are they using specific tools, or are they using the adapted guideline, or are they actually just using the gold standard guideline in the US? So we're building out click metrics to really dig into the use of the tool. And then we're looking at maintenance over time. So are those users coming back over time? And our goal is to use this very pragmatic data to actually feed back and engage with partners and adapt the tool in our implementation strategies. Okay, the next study I'm going to talk to you about is also with St. Jude. It is called the Home Heart Health Study. We also call it CARTOX. So if I say that, you'll know what I'm talking about. I'm a co-investigator on this project. It's a U01 grant. And really, I was the implementation scientist on this grant. But it does nicely align with my area of expertise because this was a physical activity intervention in adolescent and young adult cancer survivors or survivors of pediatric cancer. And this was a randomized trial of this intervention, and it really focused on improving exercise capacity in survivors who were impaired. So survivors often have sort of impairments from the treatment they went through, or they have limited exercise capacity to start. And so this is a very tailored intervention, delivering care through exercise coaches that have expertise in this population, generating an exercise plan for them and administering it both in person but also remotely through a platform. We don't have the results of this trial. So I set you up. I'm talking about works in progress. The preliminary analysis of the primary aim is showing that it did improve exercise capacity, but we're still looking at that for the final data. So my role, like I said, was to think about the implementation of this intervention. And I mentioned it was delivered in person, but also over a remote platform. And overall, patients felt this platform was usable. It was pretty highly rated as acceptable, but when we did qualitative interviews, we learned something quite different. So they didn't actually love a lot of features about the platform. And so we are focusing on now, how do we improve the platform and the delivery of this intervention so that we can scale it to more cancer survivors or survivors of pediatric cancer. So we've been working with St. Jude to develop a new platform that is more user-friendly, but also reduces the burden on the coaches who are delivering the intervention. And then our goal is to actually write a comparative effectiveness trial to see if this new platform of fully remote delivery can achieve the same level of effectiveness of the original approach, which was a mix between in-person and remote delivery. So to design this platform, again, user-centered design, I'm going to nail it home for you today. We just completed this process in May. First we started with semi-structured interviews with patients and implementers. So those are the coaches at St. Jude. And this was really, let's dig into, what did you really think of the platform? What do you need beyond what that previous platform delivered? And then we went into 3 design sessions where we were prioritizing features, understanding further what their specific needs were. And we were working with developers through this process. So it was engage with patients and coaches, build, engage with patients and coaches and build. And so we were actually showing them the platform in real time and getting feedback on it in an iterative way. We're currently in this nice tool refinement phase because this was a sprint. We did it in about 2 months, and now we need to catch up. And so the goal is now to finish the development of the tool and re-engage some of those, particularly patients and coaches, on the usability of the prototype tool. This is just to give you a little flavor of what is included in this tool. So the tool is both a platform for the coach to develop a personalized plan for that survivor, a personalized exercise plan, but also has a platform for the patient that is where they go in and actually access their plan and do the workout. They engage with their coach via a chat function. There's some gamification components to keep them motivated, and then they receive reminders and management and notification on a cell phone via push messages. Okay, I'm wrapping up. So a lot of the methods and principles that I talked about, I mentioned, are rooted in this area of D4DS. And we, of course, had to develop a digital health tool to help people use this. So D4DS, if you didn't get it, is tied to that fit to context framework. And again, this is a way of really ensuring that that product you develop can be implemented and sustained over time. And it is a engaged process. So it's meant to engage diverse partners in design, not just of your product, but design of your implementation strategy, your dissemination support, and then your sustainability plan. So this tool was not just my own. There were, these names are quite small, but a number of people here, Ross and Doug and Temby, but also at University of Colorado, Russ Glasgow, and Brad Morse and Bethany Kwan, who supported the development of this. And it is an interactive tool. So it has 2 key components. The first is an action planner, which is you log in, you create an account for your project. You can actually interact with your team and partners through activities that help you apply D4DS to your research. And it helps you to develop a dissemination plan, a sustainability plan, and also think about how this tool fits the context in the process. We launched this tool in December of 2023 at the D&I conference. And since then, we've had about 2,000 unique users, and they're using this on 96 health-related projects. And this is in 41 countries. So we have the majority of our users are in the US, but we are in other places. And do not ask me how. I did not use the active dissemination methods. We have talked about it quite a bit, but I'm not sure how it's reaching that many countries. So I wanted to just present a couple use cases of how this is being used, and then tell you briefly about where we're going with this. So the first one is by Rodrigo's team, and Drew, who's a PhD student here, did an amazing job wrapping this into a publication where they use the D4DS planner to engage partners, really diverse partners. So they had experts from all over St. Louis in transportation, and I can't even remember all the different organizations. They were seeking to engage them in really understanding the challenge of enhancing livability and needs for helping our community improve the livability of our community. And their goal was to develop what they call the St. Louis Livability Observatory. which would help these community organizations by providing this data site, basically, and track livability over time. So they engaged partners to develop a value proposition for their product in the tool, and then they thought about how would organizations actually use something like this in their own work. And that was the initial kind of step of D4DS, is really understanding the problem and thinking about the value of it to your end user. And now I think they're planning to move forward and think about the design of it and how they're going to disseminate and sustain it. The second use case is by Gabby McLaughlin, who used to be here at WashU but has moved on to Temple. And she used this in the problem of food insecurity. She was seeking to improve the use of university school meal program in the Philadelphia school system. And she had a beautiful community advisory board of a number of diverse partners. And she used this tool in supporting the engagement of that group, to really hear their perspectives on food insecurity, on the food meal program, and think about how they're going to implement this in their school system. And so they also co-designed, that was also implementation, but also co-designed a number of dissemination products to support scaling this program to other schools. So they created a brief report, they had a research brief, a presentation slide deck, and they had social media posts they co-designed with this community advisory board. So those are just two examples of how people are using the tool. We are seeking to learn more. So we just submitted an Here and Next grant to try to evaluate some of those other 96 projects that are using the tool, to really think about how our users are using it, but also how's it impacting their project and their work. Oh, yeah, I mentioned these, all of these examples of how people are using it are being placed on our website. So if you go to the homepage, there's this link, and then you'll get a pretty one-pager on the project. So those are in process of being put up on the site. It is a complex tool, so we really want to make it concrete to people how it is being used and how you could use it in your work. So that's all I have today. I just put this last slide because I'm hoping that what I talked about today really highlights what our lab does, the Health Design and Impact Lab. And these are our 4 areas: D4DS, Designing for Dissemination and Sustainability; Participatory System Science, which asks Sarah; Human-Centered Design; and then we work a lot in clinical, improving care or health services improvement. So yeah, thank you so much. Go ahead, Ben.
Great talk. Circle back to resources about SDOE. I also have a lot of experience in that area, particularly in St. Louis, and very passionate about it as well. So I just want to make a comment and a question. It strikes me there might be an opportunity where this is available to leverage what's called a community information exchange.
Yeah.
Are you familiar with that?
Yes.
And then the question, I think, kind of related to that is, what sort of work or thinking have you done looking at outcomes related to resource referral? And like, did they actually go contact the resource? Did they engage with the resource?
Yeah, I'm smiling because what a challenging question. Because we actually are working with colleagues on a public health annual review paper about how do we leverage data systems to track that, because that's quite challenging. One thing, so the answer is I haven't done a lot, but one thing we are doing in the PREVENT trial right now is we are tracking that through the community health workers are documenting in their notes in the electronic health record with a PREVENT tag, so that we can see if people are going to and using the resource. So as a community health worker follows up with the patient monthly, they ask them about, what resources have you used, which ones have benefited you, and they're documenting that. So it's one approach. It's not the solution. But yeah, that's a tough one. Yeah, Mary.
I really liked your, thanks. I really liked your creation of those personas and matching the message to the different types of people receiving it. And I wondered if you could say a little more about how you got to those personas and whether that came from some of the qualitative work. It followed that piece where you had people saying that this was a great intervention, and then when you know, probed a little more, they told you a little more qualitatively that they needed something else. I wonder if that's how you generated those people, or there was a different way.
Yeah, that's a great question. So we did a number of interviews with clinicians in LMICs around survivorship care. So that was part of the start. Was we learned really early on that many people just don't think survivorship care is their job. They're not very experienced in it. They maybe see 1 to 2 survivors of pediatric cancer a year. And so that variable of how experienced are you in survivorship care, and maybe it should be, do you view yourself as a care provider in survivorship care, was really important. That came out of the interviews. We also have a lot of preliminary data about the use of guidelines and how motivated are they to really use them, or do they have an institutional guideline, for example, that they're following? And so we thought bringing in that variable also came from interviews. Digital literacy, I don't think that came from anywhere except for the fact that I know it's important, because if they don't know how to use a tool, or maybe they are of older age range, so it's kind of an actual also capturing age here. They're going to have a very different design perspective than someone who is very, very comfortable using digital health in their clinical care. And so those are the 3 things we really focused on. We did a lot of mapping and thinking through. I think Rachel, who is part of our lab, did a lot of this work, and we kind of validated it back with end users to say, does this really capture? The other thing we used was the survey we sent out. So then we kind of did this based on what we thought, and then we went through our survey and actually categorized the respondents based on the outcomes they reported in their survey to see what did our sample actually look like. Did we have diversity across our sample through these personas? I think that they could, but we won't assess that likely. But it's a good point. Yeah.
Sorry, Ross.
Oh, Patrick.
You don't have the mic. I'm just here for the lunch. Could these personas be conceptualized as organizational characteristics? And have you thought about that at all?
Yeah, I think absolutely. We have not thought about that, but I like it. At this point, we're engaging individuals not within the same organization for this project, so they're all at different places. But I like the idea of thinking about organizational components and maybe assessing how that impacts the design as well. That's nice. Yeah, we're thinking a lot about how do we integrate both this user-centered design approach and the system science, because we're doing that in parallel. I didn't talk about the system science because you don't want me to talk about system science, and Sarah's going to do that. But we're really intentionally thinking about how do we integrate those methods. So I like that idea because you're helping us out there.
Yeah, and on that one, I wonder about if you want to really get multi-level, you could think about community clusters as well. So the individuals nested in organizations, and then you could imagine like urban, rural communities or other. That wasn't my question though. So, well, I was first thinking like on the heart association risk in the sleep one, it looks like with all this work, you don't really need any sleep. Is that right? Because it's an impressive amount of work. It really is.
I do
but
need sleep.
The question was, I was thinking about, in the AI part of your systematic review, like if you project out 5 years from now, how do you think AI would shape this work differently, and what would you need to learn? What would you be different? I know it's looking in the crystal ball, but what are you thinking around that, and how AI might make this work easier, different, harder? I don't know.
Yeah, That's a big question. My mind is going a lot of different places. First, it's going to Rachel and I took a AI and user-centered design class. So how do you actually leverage AI in this user-centered design process to either speed it up or augment it? And we learned quite a bit. So I think even just it will speed up if you wanted to do a process like this. The other place my mind is going is actually to what Mary was talking about last week, which is everyone wants these tools in the EHR. But it's definitely a trade-off. But I think AI is speeding up coding for coders building digital health tools, but also coding and how to put them into an EHR. And so I think things like that will actually speed up quite quickly. Like you can develop a digital health tool in about a week now if you wanted to. And people are being able to easily make code and put it into other systems. So hopefully that will improve. I think, yeah, trying to think about where else. I don't know that I answered your question because I don't know that you were interested in those responses. I think you were thinking broader.
I don't know what the response would be because I don't think anyone really knows, but
it's interesting.
It'll look different.
Yeah. And so the AI review paper that Amanda is actually leading, we have quite a number of reviews on the use of AI in clinical decision support. So that'll be really interesting as we dig into that about how are people actually using it in that way. And then what are the challenges for implementing it in the clinical care, but we haven't got there yet.
You could imagine like the clinical encounter.
Yeah.
You could imagine the system, clinical care, and then you could imagine the research on the different pieces of that delivery, and it's probably going to change all of those in different ways.
Right. So. Yeah.
Thanks, Maura. That was an amazing talk. I'm wondering, and I don't know, we're all asking on-brand questions. So I'll ask my on-brand question, which is to say, the broader context sort of around policy in this space, like who's going to pay for it, or how do you make it valuable enough that it doesn't need to be paid for specifically? There's obviously a lot of issues in policy on whether or not any of these tools need to be regulated or if they just sort of are part of clinical care. Like what's sort of the big picture that surrounds the sustainability of all this kind of work?
Yeah, that's a really great question. And I've thought about that most probably with the Prevent tool. And we designed that tool originally in response to a federally qualified health center. You're required to talk to any patient who has obesity about physical activity and food intake. And so what we were hearing from them is, but I don't know how to do it. And I'm not trained to do it. And I don't know how to make it personalized to a patient. So I think the maybe like easy answer to your question is that in that situation, there was already a regulation in place. And so users really easily saw the value of our tool and bought into it pretty quickly. Now that has not been true as I move that tool into different populations, like for cancer survivors, for example. We had a little bit harder time getting buy-in and by providers. It was really a clinic leader or a champion who said, I want to do this, and then brought their clinicians along. I think like from a policy perspective, that's something that has to be considered in your design. And so I think the very first step of our design is understand the problem, but also understand the context and map that policy context, map out reimbursement, map out the policies that are in place, and think about how are you actually going to design a solution that either leverages an existing policy, the example I just gave, or maybe you need to design something that's going to advocate for a policy change or move you toward that change. I don't think you can ignore that, or yeah, you're gonna your product is gonna struggle, right?